So I was tasked to give a talk on how we can possibly integrate the primary health care in clinical medicine. And as Mary said earlier, this can be quite challenging, especially since when we think about primary care, primary health care, that's usually community-based, and clinical medicine is usually hospital-based. So the outline for my talk, para magkwento lang po ako how we designed one of our internal medicine courses, which I coordinate for the college. So we started by really looking at the mission of the school. And this is what the mission statement of the UP College of Medicine says, no? Guided by moral, ethical, and spiritual values, we commit ourselves to excellence and leadership in community-oriented medical education, research, and service, using the primary healthcare approach intended especially for the underserved. So the primary healthcare approach as a way to approach healthcare is enshrined in our mission statement. So it's very important for us as course coordinators and as a college as a whole to really try to find ways to incorporate or integrate primary healthcare, the primary care healthcare approach into our course offerings. So according to the WHO and UNICEF, primary health care, as Bebel earlier already clarified, is a whole of society approach to health that aims at ensuring the highest possible level of health and well-being and their equitable distribution by focusing on people's needs. So hindi lang po yung mga may sakit or patients, but people, as early as possible along the continuum from health promotion to disease prevention, to treatment, rehabilitation, and palliative care, and as close as feasible to people's everyday environment. So from this statement, it's very important to note that primary health care really espouses a holistic approach to health, and it also emphasizes health as being a right. That's why there needs to be an equitable distribution, and its goal is really to ensure that everybody will be able to attain the highest possible level of health and well-being. And it is not just for health promotion and prevention, but through all the levels of care, from primary all the way to rehabilitative care. And as much as possible, as close as feasible to people's everyday environment, which suggests that contextualizing the care that we provide is very important. So this is what we need to try to impart to our students as we design our courses. No? So the UP College of Medicine is an organ system integrated curriculum. So the boxes here, first year and second year, are basic medical sciences, and the clinical sciences come the blue boxes. So there you see there is a progression from basic medical sciences. So this is a lot of theoretical knowledge and skills building. And then as they enter their third year in medical school, our students are introduced for the first time to clinical medicine. And this is where in LU5, my course is being taught. Okay, and the course is called Medicine 250. This is a course, their first clinical course in internal medicine. So what is Medicine 250? So it's a 3-week rotation that introduces our students to the most common medical conditions encountered in the ambulatory or outpatient setting. And the learning objectives, the summarized form, are really focused on applying clinical skills to be able to reach rational diagnosis, plan and implement a holistic evidence-based plan of management, which includes diagnostic and therapeutic management. By the end of the course, the students should learn how to screen patients who are at risk for disease. They need to demonstrate professionalism, humanism, effective communication skills, and including written documentation of all clinical data. Okay, so it's very really directed towards individual patient care by the nature of the course. The prerequisites, so we do not expect our students to have mastered their previous all the topics in their basic science courses, but we do expect them to review the pertinent topics because Medicine 250 focuses on application on processes, how to approach a diagnosis, how to prioritize, how to select and prioritize management, etc. So the design of the course was guided by this concept map, where we see an individual, and in our case, adults, who are presumably initially well. Some of them might have identifiable risks. And so we would need to identify those who might have early disease or who are at risk for various conditions through directed screening. No? And for the purpose of eventually either helping that individual maintain wellness, or if they are sick of something, be able to manage that illness early on so that they are able to regain their optimum level of health and well-being. Sometimes patients would manifest with signs and symptoms, which would require the application of diagnostic skills, so history taking, physical examination, and sometimes also the choice of diagnostic tests. Sometimes these patients can be treated on an outpatient basis, recover and become well again, or some of them may develop chronic illness. Other times, patients might require inpatient care. So for LU5 in our course, we teach the students basically this whole concept map. Inpatient care is actually what they are taught or what they learn in LU6. So in terms of connecting it to primary health care, which is the individual care, our course is really heavy on individual-based care. So we do touch on primary care in terms of the importance of coordination, continuity of care, being able to provide comprehensive care to each individual, that the adult individual. And then we also teach them how to rationally approach making a diagnosis using hypothetical deductive reasoning. So our topics here are symptoms or syndromes, clinical syndromes, rather than specific diseases. So we give our students cases which they work on to approach a diagnosis. Okay. We also talk about common illnesses, especially non-communicable diseases, diabetes, hypertension, PTB. And we teach them how to create problem lists that are complete, prioritized, comprehensive, and updated. We also teach them about how to help their patients or individuals maintain their health and well-being. This includes principles of screening and screening guidelines. We also have sessions on evidence-based medicine, but again, application, because our students have already had previous exposure to evidence-based medicine in their other courses. Okay? And then as part of a people-centered or person-centered care, we introduce the concept of shared decision-making. And especially in this time of the pandemic, we introduce them to telemedicine. So we realize that individuals are not islands, and they are within their family and the larger community. So it is important that even if our course is primarily on clinical medicine, on individual-based medicine or clinical in nature, it's important that we also provide some perspective on population health. And through our course, we do touch on the health systems framework, which really includes the various building blocks of the health system. We have activities on health financing. It is important for our students to understand how our patients are actually able to pay for the costs of healthcare. They need to understand the importance of information systems. So we have some modules on electronic medical records, as well as the social determinants of health. So what are our teaching learning strategies? So these teaching learning strategies were the ones that we implement during the pre-pandemic period, and slowly now as face-to-face classes are beginning to start. So I will highlight some of the teaching learning activities that are really specific to maybe primary healthcare, the primary healthcare approach, how we try to really integrate it in our curriculum, in our course offering, so that our students will have a broader perspective of health. No? So at the start of the course, to set the tone and the context, most of our students, the entire rotation of our students is in the Philippine General Hospital outpatient clinic, where a lot of the patients are really from the lower socioeconomic strata. So it's important for our students to understand the context from which the patients they will encounter during the rotation come from. And so we conduct this activity, a role-playing activity, where students vicariously experience the day-to-day difficulties of our patients in terms of the various economic challenges they face. And this is a game, a sort of simulation game, role-playing game that the students have really enjoyed. No? And that sets the tone. So the students actually feel how our patients there are patients' daily experiences. And that allows them to hopefully develop more empathy and understanding towards our patients before they even start their patient encounters. So this is usually conducted at the start on the first day of their rotation. Then we go into the clinical skills building. So we have patient preceptorials where they are taught they are taught to approach diagnosing a patient as well as management based on application of clinical skills. Physical examination and history-taking skills are further refined during these patient encounters. We also have small group discussions, where they work on paper cases, again, to further hone their diagnostic skills and clinical decision-making. So this happens throughout the 3 weeks of the rotation. On the second week of the rotation, around the end of the first week, the second week of the rotation, we bring our students to a local health center. In UP, as previously described, our fourth-year medical students actually go on duties at the local health center. They see patients there. So, and they do this within their community medicine rotations. So to avoid redundancy, I do bring our students to the local health center for the purpose of them appreciating the difference between a primary care setting and the tertiary care setting. So I bring them there. They are oriented to what is happening in the local health center, what it looks like, what are the services offered, who works there, what are the types of patients that seek consultation at the local health center. They're allowed to interview the various personnel in the local health center. And then their output for that field trip, so to speak, would be to compare the primary care setting, the local health center, with what they see in the tertiary setting, which is the PGH-POPD, according to these parameters. And during the processing, they do realize that we were really talking about the building blocks of the health system. What were their insights or their realizations? So they really appreciated primary care as an important foundation of our health system. And they also appreciated the context, the Philippine context in terms of healthcare. But the health system is only one part. We need to provide activities that will help them reflect on the broader determinants of health. And we do this towards the end of this session. So the end of the rotation, we wrap it up by connecting again their experiences at the start of the rotation. So we present this study that we did, again, going back to our patients, showing them what our patients spend every time they come to see us at our outpatient clinic. And through the discussion, they realize the broader determinants of health, that a lot of our patients actually do not have any choice but to come to us late or because of other factors that are beyond just their physical health. So we introduce concepts of catastrophic health expenditure and highlight the important role physician plays in terms of either avoiding catastrophic health expenditure or actually causing catastrophic health expenditure. And then we bring it back down to clinical, to the individual patient. We make them realize that being a patient is not easy. It's actually a lot of work. And as physicians, we need to try to help our patients, seeing them as people rather than as patients just with disease. So we try to bridge the patient with the actual person. So, and that's how we end our rotation. So I found this document of the WHO on operationalizing the primary healthcare approach. And on the left side of the screen, these are the components of the primary healthcare approach: integrated health services with an emphasis on primary care and essential public health functions, empowered people and communities who can advocate for themselves, either through advocating for policies to improve their health or even as self-carers or caregivers, as well as multisectoral policy and action. This is where interprofessionalism comes in. So in terms of the content, no, the curricular content, we actually are able to provide, of course, mostly on health services, but we try to touch on topics and reflections that will address the other two components of the primary healthcare approach. And yeah, so this is how it looks like, no? And we hope that through providing these learning activities, focusing on this content, our students will become more equipped with really the primary healthcare lens, so that they can contribute more effectively to improving health outcomes in our country. One challenge was during the pandemic. Some of our activities we could not do, so we could not bring them to the local health center, etc. So we tried to maximize their patient exposure or faculty exposure when they started coming. And for at the time when we could only do online, we gave them group discussions and reflective activities. So there is this JAM article on the $50,000 physical, and so we make them read. And then they discuss in small groups with certain guide questions. And then we process that all in a Zoom meeting. And then the wrap up, we do it by giving them a problem list of a patient and making them make a management plan and actually cost that management plan. And they realize how expensive healthcare is and the role they play in our individual patients' healthcare and actually lives. No? So why do we do this? Everything is really based on the outcomes that matter, and we are guided by some of principles, no, when we designed our course. First, we believe that for our students, no, to become competent doctors, it is vital that they receive a balanced training in all levels of care. That's why we really intentionally included exposure to the primary care setting, rather than just keeping them in the outpatient setting of our hospital, which is a tertiary referral center. More importantly, we want our students to be transformative leaders, problem solvers, innovators, who would, rather than waiting at the end of the line to receive patients in the clinic or hospital, would look for root causes and initiate activities and contribute to addressing the problem at its source. And this is the reason why we want to really emphasize the primary healthcare approach as a lens to looking at health. Health is not just a matter of physical well-being and health, but really it's, as mentioned, a social development issue. With that, I'd like to thank you for your attention.